Thanks, everyone. It's always great to get the last talk. It's like the karaoke that you're doing the last song, everybody's drunk. And I'm trying to, I'll give you a mixed bag of abstracts that I try to make them very engaging and also make them clinically relevant. So hopefully I'll keep you engaged for the last talk. So, these are my disclosures. None of them necessarily relevant to the slides that I'm gonna present. So, needless to say, COVID is here to stay for a long time. So we better know the implications on the gut as well. And one thing that we all know by now is that ACE2 receptors are the entry receptors for the SARS-CoV to enter the cells. But interesting enough, the expression of these receptors are more prominent in small bowel and the colon even more than lungs. But interesting enough, it's the respiratory disease that is causing trouble. And we shed the virus in the stool very commonly in the acute phase, and sometimes that outlasts the respiratory phase. But interesting enough, fecal-oral transmission of the disease is not the main route of transmission. Obviously, there was some question at the beginning whether that's true or not, especially because of the R naught of the virus being about 2. R naught is the mean number of subjects that can be, that one active case can affect and transmit the disease. And at the beginning, with the first alpha variant that we had, it was around 2. So the question was that, is this a fecal-oral transmission or not? But as we're getting the UK variant and also the Indian variant, or Delta variant as WHO calls it, the R naught has increased to 8, meaning that the transmission is rapidly evolving and getting worse, and the virus is transmitting more efficiently. And interesting enough, a disease that is fecal-oral route is very unlikely to reach that R naught. The highest that we have is polio, that reaches about 5 to 7. So that's kind of tells us that the main route of transmission is respiratory, and that's kind of good for us, especially that we do a lot of colonoscopies. I'm just going to give you this data that was published in Gut a couple of months ago that is coming from Hong Kong. What it's showing that, yes, gut microbiome is dramatically affected during the acute phase, especially if you're getting antibiotics. So one question was that, okay, we know microbiome is being changed during the acute phase of COVID, but is this the virus or the whole kitchen sink that we're throwing at patients, considering all the medications and antibiotics, and which one is it? And this study tries to address that, and clearly antibiotics are the biggest factor, and they cause a big shift in microbiome. But even the patients who did not get antibiotic, they're still having some changes in their microbiome, and this change lasted beyond recovery. So we didn't have any data on US patients, and some data is trickling in, and this is one of it that was presented at DDW. And a lot of patients have this question, okay, I got COVID, and is this going to affect me? And whether I'm one of those patients that gets long COVID, whether I'm going to have GI symptoms or not. So they had 50 COVID-19 patients in ICU, and also 9 recovered COVID-19, and 34 non-COVID pulmonary inpatients as controlled. This group of patients that they had, about 70% were African American, and 22% were Caucasian. So, and they did rectal swabs, and they looked at the microbiome. And there was relatively good news here, kind of discordant with the Hong Kong data that I just showed you. It shows that in the acute phase, microbiome dramatically changes, especially in ICU patients. That's not surprising considering all the antibiotics that we're giving during the ICU stay. But interesting enough, it appears that after the acute phase of the disease, microbiome is regressing to the mean and kind of like recovering, if you will. There were some specific changes that they saw some abundance of Campylobacter and Klebsiella in the stool of these patients. But overall, this is good news, and this is something that I tell my patients at least to give them some reassurance. Because one interesting thing is that now we need to learn about the whole concept of long COVID and whether that is going to, at least from the functional standpoint, leads to irritable bowel syndrome, in other words, post-COVID irritable bowel syndrome. There's some data coming out of Mexico that there is a significant proportion of patients showing those symptoms, but that data has not yet reflected in the US. We're doing one study, and hopefully we will have some data by ACG to show you on that. So the other study is done by the Michigan and also Tony Limbo's group that you just heard the fantastic talk from him. So this is the largest study ever done that assesses the severity of bloating, over 600 patients. And we all know in the clinic, bloating is one big problem for us in terms of diagnosis and also management. So it can happen in 16% of the general population and also up to 70% of patients with functional GI disorders. And it's not uncommon for us with the electronic healthcare to get that message from the patients that, hey, in the morning I'm flat. As the day goes along, I feel like I'm 6 months pregnant and I can't even go out. What's going on and how do I fix this? So they had 612 subjects, and they recruited prospectively, and they applied a Rumford criteria for diagnosis, and they checked numerous risk factors in terms of demographics and also other different scores. And this is essentially the summary of the results that they found. Interesting enough, the severity of bloating was spread throughout, essentially mild, moderate, severe at 38%, 35%, and 27% respectively. When they did multivariate analysis, the results were kind of interesting. Younger patients had more severe bloating. Interesting enough, gender did not light up in multivariate analysis, which kind of jives with what I see in the clinic. Some of the most severe bloating patients that I have in my clinic, in fact, are men. And also, not surprisingly, functional dyspepsia and constipation were associated with more severe bloating, and also abdominal pain and somatization score. Another interesting thing that they found is that severity of anxiety, depression, and sleep disturbances were not associated with severity of bloating, which is actually interesting. That gets me to my next slide, that in my clinic, at least, I see a lot of patients that are referred to me for bloating, and what I see is that essentially what has been done for them is that they just have been started on antidepressants and no workup has been done. And that's something that we need to improve upon, because there are multiple organic diseases that can lead to bloating. For example, in this conference, you have heard about a lot at DDW. Mast cells clearly are getting hot. And I mentioned it at the bottom there with mast cell activation syndrome. But there are other things that we shouldn't miss, for example, anatomical, enteroceal, hypermobile Ehlers-Danlos syndrome. This is something that is diagnosed purely clinically. There is no genetic test for the hypermobile Ehlers-Danlos syndrome, so just essentially on physical examination that can be diagnosed. And very commonly, these patients have abdominal bloating and distension. Motility issues, pseudo-obstruction, gastroparesis, rapid gastric emptying, and intra-abdominal adhesions, which can be de novo, or it can be because of surgery. And also microbiome related, which is something that we think about right away about bloating, whether small intestinal bacterial overgrowth, fungal overgrowth, and more data we're having that sometimes even probiotics can cause a bloating. Sometimes when I have a patient that comes to the clinic and they have bloating and they have been started on probiotics, actually I give them a honeymoon on the probiotics to see if that actually helps them. in terms of bloating. And also the concept of post-FMT irritable bowel syndrome that is getting more and more attention that can lead to bloating and abdominal distension. So I put this slide up to think about some organic causes of bloating, and because when you diagnose any of these, obviously the management completely changes. So another interesting trial that I want to present is an area that we almost never pay attention to, and that's GI disorders in pregnancy. So this is a very nice study done in Lithuania and about preventing hemorrhoids in pregnancy. So the incidence of hemorrhoids in pregnancy as per previous data is about 15 to 40%. And this study showed that in fact is 41%. It's very common. And one difference between hemorrhoids during pregnancy as opposed to hemorrhoids with men and women of the general population that without pregnancy is that the majority of these cases, they don't have constipation. And hemorrhoids is likely is being caused by increased blood volume and also increased intra-abdominal pressure, and also relaxation of the smooth muscles because of the progesterone, and some because of the constipation. That's very important because so many times if you see a patient with hemorrhoids and pregnancy, the first thing that you reach for is a laxative. And in fact, that will lead to more bowel movement and make the constipation worse. So what did they do? They essentially, they randomized patients into two groups. A group that received dietary and behavior recommendations that I'm going to get to. And also the other patients were randomized to routine practice. So this was single-blind, multi-center trial in Lithuania, and they had 260 subjects. And the endpoint was reduction in postpartum rate of hemorrhoids. So these are the dietary recommendations, and in fact, actually, this is the slide that is important for this study. So the recommendations were consume at least 1.5 liters of fluid. The second recommendation was to take a tablespoon of bran and 2 to 5 prunes daily. I do this in patients who develop hemorrhoids during pregnancy but has had no functional GI disorders before a pregnancy. Reason why is that if you do this in somebody who has had functional GI disease before pregnancy, they get really bad bloating. So be careful with the second recommendation there. And consuming fruits and vegetables and nuts that we're suggesting. But the behavior recommendations are the most important things in this scenario. Exercise 30 to 60 minutes daily. And what I generally in my practice recommend is that even if you're going on a treadmill and you're going even with a speed of 2 miles per hour, that's good enough. Go for it for at least 30 to 60 minutes, and that helps dramatically with the GI health and also the hemorrhoids, interesting enough, likely in the setting of improving blood flow. Another important thing is the spending no less than 3 minutes on the commode, and that's very important, especially in pregnancy and any hemorrhoids in general, especially these days that we have our cell phone and you don't know how time has passed, and all of a sudden you have been sitting there for 20 minutes not knowing that you have answered 5 emails already. But that's one thing that I tell them: do not take your cell phone into the bathroom. And another thing is that washing after bowel movements, and that's what I generally recommend to them. And I actually ask them to get a bidet. You can easily get bidets from $50 all the way to $800 that you can just install on your regular toilet, and this helps dramatically. So all the last 3 recommendations are key management of hemorrhoids in pregnancy. So what they saw was a dramatic drop in hemorrhoids. As I mentioned, they found 41% of patients during pregnancy and even postpartum having hemorrhoids, and so clearly we miss many of these cases. And they dropped it by 25% by just those recommendations, and very good results. All right. Oh, another point is that there was no changes in fetal or maternal endpoints, considering that they were giving a more bran and also a prune, so there was no issue here. So this is what we published about 2 or 3 months ago in terms of management of pregnancy and management of IBS during pregnancy, which is actually very tough because there are not many options out there. Is that, I'm supposed to stop? No, we're good? All right, all right. All right. So another interesting abstract that I want to present is something that kind of relates to our practices, because I get a lot of patients talking about this, talking about colonics, and also showing up in your clinic with these reports about stool microbiome that are 10 pages about different bacteria, and you have no idea how to interpret. So I present this data to kind of like open that discussion and give you some clues how to answer those questions that patients have. So colonic, at least in California, is getting a lot of attention. There are multiple colonic centers out there. And the way it's done is essentially with multiple techniques, but essentially they put something similar to rectal tube, and they let the water to flow roughly for about half an hour to 45 minutes, and sometimes they do abdominal massage, and then you evacuate. So that's considered a colonic. So multiple techniques, and in fact, actually in California, because we tend to opt whatever we see. Now, if you look around, there are colonics done with peppermint in them. There are colonics done with coffee in it. So actually, I have to admit, the coffee enemas is an interesting concept, because there's data to show that there is colonic absorption of caffeine. So you'll get a buzz out of it, that's for sure. But obviously, there is no obvious evidence to show that this detoxification is beneficial. But it has been looked at for refractory constipation, and also preparation for colonoscopy in cases that are they're not willing to take oral prep or are unable to do so. So this is one device that this study was done with. And what they did is that they had 20 subjects that underwent high volume colonic irrigation before their colonoscopy. And they took stool samples at home. And after that, during the colonic, they took 3 serial stool samples as well. And they run a metagenomic sort of sequencing, and even a shotgun sequencing on these stool samples from the same subject. So this is the interesting thing. So when they looked at the stool samples of the same patients, there was a significant difference in both alpha diversity and also beta diversity of the stool samples. So this just shows you the microbiome of stool sample, depending on which part of the bowel stool is going to be different. Which gets me to my next point, that stool studies, although it's the most approachable and easily achievable sample for microbiome assessment, it's not a reliable medium for assessment of the microbiome. And that is why more and more we're moving towards small bowel microbiome, and also mucosal microbiome, which are probably more clinically and pathophysiologically relevant. So, and also another conclusion that you can get out of this study is these reports that patients come with to your office that, hey, I've paid like $1,000 for this, it better be right, what do I do with this, right? And this is essentially what I tell them. Essentially, there is not much inference that you can get out of those tests. Why? Because there is a large range of normal stool microbiome. It's almost probably would be impossible for us to define what is a normal stool microbiome eventually. And that is why in the research field we're starting to stay away from it. And more importantly, it's even worse in the stool microbiome of the disease. It's even more variable, and it's very hard to differentiate what's right and what's not right. And and there is it's been shown that there is daily variability of stool microbiome in children, in adults, and even in elderly. So that's another issue that we have with assessment of stool microbiome. And this study also shows that even within one bowel movement, the stool microbiome is variable. So which one is right? Which one is the one that we're supposed to look at? So those are all deficiencies of stool microbiome assessment that probably we won't be able to overcome. And more importantly, at the end, normal doesn't mean healthy. So you saw the data from for FMT from Dr. Lembo. That's still, the jury is out what to do with FMT and IBS, whether you need super donors. But one study in Denmark that they did is that they looked at the stool microbiome of IBS patients, and they gave them healthy FMT. And after that, the stool of the IBS patients did look like the healthy donors, but the symptoms did not improve. So necessarily, normal is not healthy. So that's one thing that in the stool microbiome is still struggling to figure out, and that's a challenge for FMT studies. So with that, I'll just gonna hold off, and that's it, and I'm ready to answer questions.
Thank you, Ali. Thank you both for great talks. The chat session is open, and we've got Tony on the line.